I'm Michelle Kenny. I'm the clinical coordinator on the joint replacement unit here at Johnston Willis. So the purpose of this class is to get you ready for your hip replacement. We want you to know what to expect before and after surgery, okay? We want to prepare you for your joint replacement, give you time to get your house ready. We want to make sure that if you need to tidy up and declutter, you have the time to do that. You want to move any scatter rugs that may be in the house. You're going to need to make room for that rolling walker, so you need a nice path for that, okay? If you are going to be going home by yourself, give you time to prepare some small meals for yourself, so all you have to do is warm those up. If you live alone, to coordinate some help. You're going to need some help the first couple of days when you get home, preferably 24 hours a day if you have someone, so you have time to get that ready. Reduce your anxiety level. The unexpected is always, makes us a little anxious. Make you aware of your expectations. You're in charge of your recovery. We want you to participate and communicate. Early ambulation, you're going to hear this so much, motion is lotion. You're going to hear it so much. I wanted to have t-shirts made that said motion is lotion. You're going to probably get tired of hearing it, but it's so true. When you sit, you get stiff. When you move, it may hurt initially, but it's going to feel better each time you move. And then we want to transition you to home. You'll either be going home with home PT or outpatient PT, depending on what your surgeon has ordered for you. Going to some type of a rehabilitation or a skilled nursing facility is normally not what the doctors like. So you can expect a 1 to 2 day hospital stay. Sometimes it's just overnight, depending on how you do. Bring a coach for support. We appreciate all our coaches being here today. Pain management. This is going to be so important so that you can work on your physical therapy. So you're going to hear assessment, reassessment, move, and medicate. So the nurses will be assessing your pain to see what your pain number is. We go by a 0 to 10 pain scale here. 0 being no pain, 10 being the worst pain you've ever felt. We never want to see you there. Once we give you pain medicine, we're going to be reassessing your pain to see if that pain medicine is working for you. Sometimes it has to be, we have to change your pain medicine if it's not working for your pain. We want you to move, and then we'll keep you medicated so that you can work with your therapist. We want to return you to a more active lifestyle, increase your quality of life. We want to get you back to the things that you enjoy doing. And we want to make your hospital stay a quality experience. So with any type of surgery, you're going to have risk factors. The first one being a blood clot, which you'll hear also called a DVT. You'll be receiving medication, anticoagulation medication, to help prevent this. Also, you'll need to keep moving. We tell our folks, I don't know if you guys have ever heard of ankle pumps. You're going to keep those feet moving, keep that blood flowing to cut down on your risk. Also, you'll have SCDs on your calves. They rotate. It's a little pump that pumps, and it actually blows up, and you'll feel it rotate from calf to calf, and that's also helping to keep the blood flowing. And you'll have those on the majority while you're here, especially when you're in bed. A pulmonary embolism, also called a PE, is actually when the clot has traveled to your lungs. You could experience problems with anesthesia, nausea, and so forth. You're at risk for infection, and Amanda is going to talk about infection a little bit later on in the class. Blood loss with risk of transfusion. We will be monitoring your labs each day after your surgery to see if there's a risk there. Any underlying medical conditions, and then any problems with wound healing. We'll be assessing your wound daily, several times a day actually. So these are some of the things to stop taking 5 to 10 days before surgery. The first one being aspirin. Any type of an NSAID, Motrin, ibuprofen, Aleve, you'll want to stop taking that. Herbal supplements, fish oils, and so forth, you'll want to stop taking those as well. You can take Tylenol for pain. And if you're on a blood thinner, you're going to ask your doctor before stopping that. So if you're taking a blood thinner for AFib or something like that, that's something you need to have a talk with your doctor about, okay? So anytime you have surgery, that you can't eat or drink after midnight. So the day before, actually a couple days before, you want to really, really hydrate yourself. You want to drink lots and lots of fluids. You want to eat small meals. You don't want to have a T-bone steak the night before you go in for surgery. We want to make sure you're eating those small meals and they're passing through. You will have an IV for the first 24 hours or less, depending on how you do. That's going to hydrate you as well. The body is 70% water, so you can see why it's so important to hydrate yourself. You're going to have narcotics for pain, and they're metabolized by either the liver or the kidney, and flushing with water is good to get that out of your system. You could experience nausea caused by dehydration. not eating before pain medicine, and also if you're hypersensitive to pain medication. So you want to make sure what we normally do here at Johnston Willis, and I'm sure at Chippenham they do it as well. We have a nutrition room on the unit here. We fill a little cup with some crackers and so forth, and we bring that to your room. So when you're calling out for pain medicine, you want to grab a cracker. You want to get something on your tummy. You do not want to take a pain pill without having something on your stomach, okay? Things to bring with you. Personal hygiene products, your toothbrush, your toothpaste, deodorant. If you forget these things, we have a whole supply room full of them, so don't fret. Shoes with a good sole, such as tennis shoes. You don't want to bring your flip-flops, as cute as they are. Please leave those at home for this trip. Loose-fitting pants, so important. You're going to have some swelling. You don't want anything tight on. We would like to see maybe elastic sweatpants, you know, little capri, pajama bottoms, something comfortable for the men. They like to wear the athletic shorts. Also, you don't want anything with buttons because you're going to be holding onto a walker and you'd have to let go to button that. Plus, it's going to be too tight fitting. So stick with something really loose and allow for that swelling, excuse me. Medical equipment, a mask for the CPAP machine. If you sleep with a CPAP at home, please make sure you're bringing your mask and your settings as well, and we'll have respiratory therapy set you up with that. A copy of your living will and advance directive, we'll put that in your file, so we'll have it. And you may need some money on the day of discharge for your prescription. We have a Walgreens here at Johnston Willis. Chippenham does not have one at the moment. So if you would like to, we can send your prescriptions down to the Walgreens, and the day of discharge, they'll deliver those to your room. They'll call you if you have a co-payment. You can pay it over the phone. If you have a credit card or if you have cash, they can make cash or change in your room. It's really nice. If there's an issue, we can take care of any type of issues here while you're still here. So that's an option for you. What to leave at home? Again, button trousers, any tight-fitting clothes, valuables, jewelry, and credit cards. Now we have credit cards, but we have case management that will be coming to see you. If you need some medical equipment, such as like a rolling walker, and you have a co-payment, that will need to be paid for before it's actually delivered. So if you want to bring a credit card or some extra cash, or have your coach or your spouse bring the credit card, we can make sure that's paid for so you can get your walker delivered and go home with it. Large amounts of cash are not necessary. And again, those flip-flops, just leave them at home, and the house shoes. All right, so now we're at pre-admission testing. So 3 to 4 weeks before surgery, you're going to be doing your pre-admission testing. At that time, you want to bring all your medication bottles with you, any type of prescription medications, as well as any type of supplements that you take. We want to know everything that you're taking on a daily basis. That time, they're going to also be doing a history and physical, which is performed by either a nurse practitioner or a physician of the hospital. They'll do all necessary testing that day, such as EKGs, blood work, any type of labs, x-rays. So plan to spend at least 2 to 3 hours here. You're going to be here a little while. Also, they'll do a MRSA screening. So if you do test positive for MRSA, your surgeon will be notified. And what they'll do is the surgeon will call in a prescription for you. Usually it's a different type of cleansing wipe, as well as some ointment that you put in your nares, your nose. And then when you come to the unit the day of surgery, the orthopedic unit, you will be on the med-surg side rather than the orthopedic unit. So here at Johnston Willis, the med-surg is it's our sister unit. It's right beside the joint replacement unit. And then at Chippenham, I believe it's on a different hall. Okay, so here you are, same day surgery. They're going to go ahead and start an IV and start giving you some fluids. You're going to have the anesthesiologist come in here and talk to you about anesthesia. Most of the patients get a regional anesthesia, which is a spinal, and it just numbs the area that's going to be worked on. So for instance, your hip, or if it was a knee, it would just numb you from the lower abdomen down. It's usually a little injection in the lower back. If for some reason your medical history would show that you would not be able to get that, if you've had some type of back surgery or back issues, you may have to get general anesthesia, and that's where they put you to sleep, okay? With the regional, even though you're just numbed from the stomach down, they still give you sedatives, so you will not remember the surgery, okay? So site identification and surgeon site marking, so the surgeon will be marking the site that's going to be operated on, okay? If you have any questions for the surgeon, that's the time to ask them. You want to be on time. If you're late, it makes the next case late, and it's just a chain reaction, so please try to be here early. You'll get introduced to the staff, the nursing, anesthesiologist, and anyone else helping with your case that day. And then they're going to hook you up to monitors to monitor your blood pressure and your heart and so forth. So from the same day surgery, you'll be moved to the operating room. They'll put you on the operating room table. Again, you'll have monitors applied to you to monitor your blood pressure and your heart and so forth. They'll administer your anesthesia, depending on what the anesthesiologist determined was best for you. You're going to get a Foley catheter inserted. You won't remember it. If you're having a same-day surgery, you will not have a Foley catheter. For our gentlemen, the catheter will come out, you'll have it in the day of surgery. It will come out early the next morning, usually like 5. He works with you that next day to determine that you can get safely to either a bedside commode or the bathroom, okay? Your surgical procedure will be performed. You could possibly have a wound drain. Some of the surgeons use them, some do not. And then when you wake up, you go to the PACU. And that's the post-anesthesia unit where you'll recover. All right, so now we're in the PACU. You'll again be introduced to the nursing staff there. They're all great. They'll continue to apply monitors to check your vital signs closely. They'll ask if you can wiggle your toes or move your legs. They're checking to see if that anesthesia is beginning to wear off. Again, check the level of spinal regression. They're going to monitor your pain level here as well. When you start to wake up, when those toes start to move, that's when it's time to ask for some pain medicine. We normally like to start you on oral medication, and that takes about 45 minutes to an hour to actually kick in. So we want to make sure that's on board before that pain starts to kick in. Again, we're going to monitor drains if you have them. Continue to administer your fluids. You'll be there for at least an hour in the PACU, and then you'll come to the joint replacement unit. Or same day if you're going home. All right, so now you're on the orthopedic unit, either at Chippenham or Johnston Willis. You're going to meet the staff. That's going to be the nurses on the unit, your nursing techs, the therapist, and so forth, and then our nurse practitioners. They're going to do a head-to-toe assessment, check you over, check your wound, check your blood pressure and so forth, and continue to do that periodically. If you come to the unit before 2 p.m., you will be evaluated by physical therapy. If for some reason you come a little bit later than that, the night shift nurse will sit you up on the side of the bed. That's part of your therapy for that day. And that's also called dangle. So if you hear dangle rather than sit up on the side of the bed, that's what that means. If you work with therapy and you're able to walk, they'll walk you. If the anesthesia is worn off and you're able to take a little walk, they'll do that with you. Again, we'll continue to monitor your vital signs, assess your wound dressing. You're going to continue to get those IV fluids. We've got to keep you hydrated. And we do ask that you limit your visitation on that very first day, just because you're going to be tired. This is where your coach really comes into play, so they can, if people insist that they come see you that day, just have short visits. You know, let them stay 15, 20 minutes, but you really need to rest, because you haven't slept good the night before either, so right now you're probably pretty tired. Okay, exercises. This is your daily routine. We talked about the ankle pumps at a minimum 2 hours while awake. So every 2 hours you want to do those ankle pumps. What I have my patients do is if they're watching TV and commercials come on, they're doing ankle pumps the entire time that the commercials are on. You want to keep that blood flowing. It's very, very important. And set of spirometer. Every 1 to 2 hours while awake. And I brought one. This is clean, so it doesn't have any germs on it. So most people think that when you see this, you actually blow into it. You got to move that up. You actually don't blow into it. You fill your lungs with air. Nice and slow, and then you release. And that's going to move this up. So as you begin to move it, you're going to mark where you actually got it to. You're going to use this 1 to 2 hours while awake, about 8 to 10 times. Very important to keep your lungs good and healthy after surgery. Cough and deep breathe every 2 hours while awake. Turn and reposition yourself every 2 hours while awake. May not be able to, so definitely ask your nurse or your nurse tech to reposition you, because you've been on your backside most of the day. We want to try and get you off of that. And then exercises as indicated by your therapist. They are going to give you a printout of the expectations for exercises, and they'll give those to you when you get to the unit as well. So the pain that you're going to experience after surgery will be different than what you're experiencing now. You're going to have muscle healing, you're going to have bone pain, incision pain, and you're going to have swelling, okay? Again, our pain scale is 0 to 10, 0 being no pain, 10 being the worst pain. If we can keep you somewhere around a 5, that's pretty comfortable enough that you'll be able to do your therapy and so forth, okay? So because you will not be pain-free. So again, 5 is the magic number to stay close to and stay ahead of your pain. Each patient's room has a whiteboard. On that whiteboard, you'll see what type of pain medicine we started you on, what time you received that pain medicine, and what time the pain medicine is due again. That medicine is not scheduled, so you have to ask for it, okay? So for instance, it's 8 o'clock in the morning and we gave you a pain pill. Let's say we gave you Dilaudid. It's due again at noon, so you'd want to call your nurse around 11:45 and say, hey, I see where my pain medicine is coming up. Grab yourself a cracker, and then she should be there on time to give that to you, okay? And this is necessary to meet your therapy goals. You want to stay ahead of that pain. You want to take it every 4 hours, you know, while you're in the hospital so you're able to work with therapy. Okay, so there's 2 different approaches that the surgeons use as far as the hip replacement. The first one is the anterior approach. The incision is more towards the front here, usually about this long. The estimated length of stay is usually 1 night with that. There's typically no hip precautions, but that's also going to be determined by your surgeon too, if you do have some precautions with that approach. And then we have the posterior approach. Generally, this length of stay, you're going to usually plan on spending 2 nights with us. Posterior hip precautions, no crossing of the legs or ankles, no internal rotation. You want to kind of keep those legs nice and straight, those feet nice and straight, and no flexing greater than 90 degrees, so no bending to pick up things off the floor.
We are the orthopedic nurse practitioners here at Johnston Willis, so if you are a Dr. Wind or a Dr. Jones patient, you will be seeing us every single day. To discuss a little bit about our role, we'll be seeing you from the moment you get up to the orthopedic unit. We'll be seeing you every day. We will be doing all your discharge paperwork, printing out your scripts. You will see your surgeons. You may see their PAs, but typically they go back to the clinic and then we stay there all day to manage your pain and take care of any issues that come up. There are 2 PAs at Chippenham, Jesse and Christy, and you will see them if you are with Dr. Miller and Neduff and any other crew over at Chippenham. Okay, so they are available to you as well. All right, I'm going to talk just a little bit about case management. So once you come up to the floor, for all of the hip patients, we like for case management to see you right away, because if you're an anterior hip, potentially you could go home the next day if you clear therapy. And we want to make sure that we have all of the walkers ordered and everything that you need before you go home. So they're going to visit you in the hospital. They're going to set up any type of home health if you have that. They're going to set up order any walkers, any bedside commodes and things like that, and talk with the insurance, and they let you know if there's a copay or anything going on there. They can also review your advance directive if you don't have one. Also for the outpatient physical therapy, that's something that's set up by the office, so case management will not be doing that. That's a conversation you've already had with the surgeon, and typically when you come in, you already have your date of your outpatient therapy set up. So we're going to talk a little about blood thinners. I know that the surgeons have talked to you about that previously. So all of the patients, all of you will be on a blood thinner, typically post-op day 1, either the evening of surgery or the next day, depending on what your blood thinner is. And you will be on it for a duration of time that's established by the surgeon. Unfortunately, it's not standardized, so all of the surgeons do something different, but we make sure that you're aware of that before you leave, and we give you a prescription with the correct amount. So the blood thinners typically slow down the clotting process, and they prevent formation of a blood clot. So you're a little bit higher risk after surgery for getting a blood clot because you're not up and you're not moving as much. You're more horizontal than you are vertical right now. So what we want to do is we want to make sure we thin that blood so that clot can't form. And we are coming in and assessing you every day to make sure that you're safe. So these are some of the blood thinners that you're going to see. Lovenox is an injection. It's a little injection, a little stick that goes right into the tummy. It could be once a day, it could be twice a day. It just depends. Xarelto is a pill. It's it's a pill that you take every evening. There aren't any blood tests that you have to have for this. There isn't any food that you can't eat. Aspirin. When we do the aspirin, it'll be a full strength aspirin, 325 milligrams twice a day, and then the duration will be based on the surgeon. Coumadin and Eliquis are not typical blood thinners that you see unless you're already on them. So if you are on these chronically at home, we don't want to change that around. We hold it for about 5 to 7 days prior to surgery. We restart it when you come in. We have pharmacies sort of dose your INR a little bit. And then typically once you go home, you go back on what you were taking at home. Like I said, Coumadin has daily blood work for an INR, and we have pharmacy dose that. All the blood thinners are determined by your surgeon. We educate you prior to going home. So for those of you, if you're worried about that injection, we make sure you're educated. And all prescriptions will be given to you at discharge. So some of the side effects of the blood thinners, the big side effect is going to be abnormal bleeding. So this isn't, I brushed my teeth and I had a little bit of bleeding, because that's normal. What we look for is I brush my teeth and it will not stop bleeding, and it's been an hour. Any kind of bloody stool, so if you're going to the bathroom and you notice that it's discolored, if you should cough up blood, have a nosebleed that won't stop, any vomiting blood, you want to stop the medication immediately and you want to call your surgeon. So all of your home medications will be adjusted. So once we've decided that you're safe with therapy and your pain is controlled, we will start to look at those home medications. So we'll make a decision on what prescriptions we're going to give you, which typically is your blood thinner and your pain medication and maybe a stool softener. We're going to stop any medication, so any hormone replacement therapy will be stopped. Non-steroidal anti-inflammatories will be stopped. So all that conservative treatment you had with Mobic and diclofenac and ibuprofen, those will be held while you're on the blood thinners. Okay? And there may be some over-the-counter medications that you take, like garlic and things like that. You'll see that we'll hold those as well. Once you're off of your blood thinner, then you'll be able to start some of those home medications back if you need to. All right? We are also the surgeon's going to determine your therapy needs, like I said, so that would be home health or outpatient therapy. Your outpatient will already be set up, and your home health would be set up by the case manager. All follow-up appointments, some surgeons have a follow-up appointment card. You're going to get it at discharge. The appointment's already going to be set up, and it's also going to tell you who you're going to see in the office. If that date doesn't work for your schedule, you just call the office and they'll change it. Otherwise, you'll get in your discharge paperwork to call the office with the phone number to set up your appointment and who you should set it up with. Dressing changes and shower instructions, those are also going to be discussed at discharge. Since all of the surgeons do something different, we would be here for at least another hour today going over that. So each of you, I gave a sheet of paper, and it has your surgeon on the front of it. It's a surgeon-specific sheet. Basically, that goes over any dressing changes for your surgeon only, as well as any discharge information when you can shower. So that way you each kind of know that prior to coming in, and we're going to discuss that with you many times. And you get a copy of your discharge instructions and everything that they go over. Okay? All right. If you're going home the same day of surgery, they'll order any crutches, leg braces, anything that you may need based on the surgeon's individual needs. So coaches, this one's for you. Support at home. It's very important that you have someone there at least for a few days, AM, PM. This could just be someone running errands for you, someone getting groceries for you. You want to make sure that when you get home, all your throw rugs and things are moved, cords. You want to have kind of a wide berth because you're going to have that walker and you need to be able to get through your house, okay? When you get home, maybe you've done the stairs here and you've cleared therapy, but when you get home, that's the very first time you're going up those stairs, so you should probably have someone with you as you try to make that trek, okay? All right, and lastly, you will be able to take care of yourself, but you're going to be tired. You've been through a rough couple days, so you're just going to need someone there for support. All right, like I said, remove all the throw rugs and cords from the floors at home. We don't want you to fall. It's very important. You want to, as far as exercise, the therapist is going to come in and go over some things with you and give you some sheets for your exercises. But you don't want to sit for more than 45 minutes at a time because you get stiff and you have swelling. You want to walk frequently but not long distance. Walk on flat surfaces, wear good shoes. Like Michelle was saying, no flip-flops. You can do slip-in shoes if you would like. You can do shoes that tie, something that's comfortable, something that has a back to it. You want to apply ice frequently. So typically in my discharge paperwork, I tell all the patients that I would ice 20 to 30 minutes about 3 to 4 times a day. And I would specifically focus on right after therapy and right before you go to bed. You want to elevate your leg frequently. So as far as swelling goes, you're going to notice that you're going to have more swelling when you get home than you did when you were in the hospital. And the reason is you can't go to the kitchen here. You can't get up and go to your bathroom and do the things that you want to do, and you're going to be moving around more. So the more you're up, that leg could swell. We want you up and walking, but I want you to listen to your body too. If it's telling you you're doing too much, then you are, and you need to go ahead and sit down and elevate it and ice it, okay? If you go to the doctor or dentist, you may want to just let them know you had a joint replacement. Some of the surgeons and some of the dentists like to pre-medicate with antibiotics prior. So if you should have a sudden increase in pain, and so this is, my pain is controlled, I'm feeling pretty good, I've been at home now for 4 days, but now I have this spike of pain and I'm taking my pain medication and it's not working and it's getting worse and it's swelling worse. That's something new. You want to call the surgeon for that, okay? If you get home and you have a temperature of 100.0, and then you recheck it and it's 99.5. That's okay. Sometimes you can have a little blip in your temperature post-operatively after your surgery. But what we look for is it 101.5? I'm taking Tylenol and it's still elevating up. At that point, something's going on, okay? It's consistent. We want to call the doctor. If there should be an increase of drainage from your wound, so it wasn't bleeding, but now it is. It's starting to drain something, it kind of smells, it's discolored, we want to call the surgeon. Any kind of persistent nausea and vomiting. So if you were in the hospital and you were taking your pain medication, but you were feeling nauseated and we sent you home with something for nausea, and then that's normal. But if you weren't having any nausea, or now you are experiencing nausea and it won't go away, and maybe we've called something in, or you just keep vomiting, you want to call the doctor. These are all reasons we would want you to call the surgeon's office. And know that all of the offices have an after hours number. So when you call the office, if they're closed, they give you the after hours number. It gets triaged by a nurse, and usually within 60 minutes, one of the surgeons will call you. It might not be your surgeon, it might be whoever's on call, but they will answer that phone for after hours and on the weekends. Now, if you get home and you have chest pain, shortness of breath, your heart feels funny, I do not want you to call the office. I do not want you to wait for 60 minutes. I want you to call 911, and I do not want you to drive yourself. And if you have a coach, this is where you'll come into play. So just the differences between something to call for the doctor and something to call for that's more emergent. Michelle talked about Walgreens. So we do have Walgreens here at Johnston Willis. It is available for your convenience. You do not have to switch pharmacies if you are a CVS member. We don't give you any refills. We give you exactly the number of blood thinner you need. We give you at least 2 weeks worth of medication that'll get you to your 2-week follow-up. So if you want to use that, typically what happens is we electronically send those down. If there is an issue with the insurance, they have me on speed dial, so they know how to get in touch with me. I can make those changes if we need to and send them to another pharmacy. Otherwise, if you do, they'll give you a call on your phone. They let you know if there's a copay. They'll ask you if you want to fill the prescriptions. You say yes, they'll bring them to your room. So this is where you might want to bring in a little bit of money in case there's a copay for your prescription. Okay. Now, some insurances you might not have a copay, and it might be a zero charge. This is Jennifer Osborne and Todd Campbell. She's the director, and he's the manager of the 3rd floor here at Johnston Willis. They manage the orthopedic unit and the med-surg unit. If you're at Johnston Willis, you're going to be seeing these 2 people every day. They do daily rounding. Their role is to make sure that the quality of care that you're receiving meets your expectations and the expectations of the hospital. If there are any issues, you would let them know, and then we would try to rectify that situation for you. Okay? And then lastly is, you're not on this journey alone. Okay? We're going to be with you every step of the way. We make sure that your pain is controlled and that you're safe to go home before you leave. If you have any other questions, I'd be glad to answer those. We're just waiting for the therapist to come down, and she's going to go over some therapy with you, expectations of what you're going to see when you're in the hospital, and then some for when you're outside of the hospital.
I'm Katie. I'm one of probably 16 physical and occupational therapists that work here at Johnston Willis. Okay, so you may see me, you may see one of my colleagues when you come in. My goals today are just to sort of walk you through the first 12 to 24 hours with the physical and occupational therapy department, so you sort of know what to expect. If you have any questions about specific home situations, I'm happy to stay for a few minutes after the class and answer those to your specifications. If not, then we will certainly be covering that when you get to the hospital and meet with us individually after your surgeries. Our initial eval depends on what time you get to the orthopedics unit. Here at Johnston Willis, if you're on the floor by 2 p.m., we will see you for your initial evaluation. Now, some of you may be going, okay, I just had major surgery that morning, and now it's 2 o'clock in the afternoon, and you want me to get up and walk down the hall. No, I do not want you to get up and walk down the hall. I want to come in and go over our exercises with you so that you can be doing those as you're able to throughout the evening. And I want to sit you up on the edge of the bed and make sure your blood pressure is stable. Start teaching you any hip precautions and educational things that come along with your surgery. And then I want to stand you on the edge of the bed using a rolling walker if we think it's safe. And at most, we may take some side steps up to the head of the bed for positioning so that when you lay back down, you're nicely settled in the middle of the bed. Okay? If you're having an anterior hip procedure and your blood pressure looks good, we do tend to take you for a walk as far as you and your blood pressure will allow us to do. Okay? If you're having a posterior hip procedure, because of those precautions, we really just focus on that first stand and going to the head of the bed and just doing some side stepping at the edge of the bed. We don't typically walk you away from the bed at that point. Okay? So hopefully that gets rid of some of your fears about us coming in on that day 0 day. If you arrive to the floor after 2 p.m., we won't start with you until day 1. Okay? The biggest difference between what I'm going to do with you on day 1 versus day 0 is by then you're a little more stable, your nerve block's worn off, you're feeling a little bit better. So at that point, we do actually get you to walk as far as you feel like you can with us. All of our recliners in the department are on wheels, so all of us walk you with a safety net. Okay? So you don't have to have fears of getting out into the hall and not being able to get back to your room. We're going to bring the recliner with us for probably the first day or two. It'll be carried behind you so that if you start to feel dizzy, woozy, nauseated, or you just can't go any further, we can sit you down and safely return you back to your room. Okay? Safety is our number one concern with our patients, so we're not going to put you into any precarious situations that we don't think we can handle. Okay? Therapy is completed twice a day, Monday through Friday. On Saturday and Sunday, we see you once a day. So you only get 1 session with us. For those patients, if you're having surgery later in the week, sort of Thursday, and you're going to be there Friday, Saturday, and potentially Sunday, we do try to get you independently doing your exercises so that even though we're only seeing you once, you know how to manage your own joint replacement before we release you to once a day over the weekend. For discharge, your book will have very specific distances that we expect you to walk and things like that. We updated that a little bit. For discharge, our main focus is on your independence within your own home environment. So when we meet the first time, we're going to ask you about 1,000,001 questions about what you need to do in your own house. Things like, is it a 1-story or a 2-story or a split level, or where do you live kind of idea. How many steps do you have to get into the house? How many steps do you have to get to the bedroom? Are there railings on those sets of stairs? Is there going to be somebody there with you during the day that when you need a drink of water, they can run and grab it every once in a while? Or do you really need to be able to get to the kitchen and make your own lunch because your caregiver is off at work every day? Okay, so we're going to be very specific. And then for discharge, we're going to make sure that you can do all those things that you feel like you need to do independently and safely before we send you home. Globally, though, we would like to see you be independent in completing your bed mobility and your transfers out of bed and out of a chair to a rolling walker. Most of our patients do go home on a rolling walker. We want to see you walking a functional distance based on what your house looks like. So if you live in a little house, you know, tiny house living is a big thing right now. So if you live in a little house, you only have to go 20 feet from your bed to your bathroom, then I'm going to focus on independence at 20 feet. If you live in a mansion and you've got 3,000 feet between your bed and your bathroom, God bless you for cleaning that. I'm going to make sure you can walk 3,000 feet from your bed to your bathroom or your kitchen or living room and all of that stuff, okay? So we typically are striving for 150 to 200 feet, but independence is our focus more than the distance. As far as stairs go, if you have no stairs at home, you live in an apartment and you use an elevator, I'm not going to worry about stairs with you. I'm going to focus on the exercises, the bed mobility, the transfers, and the independence with walking. If you have 3 flights of stairs to get to your bedroom, we're going to take you up and down 3 flights of stairs before we clear you to go home, okay? Depending on the rails and all of that stuff. We're going to help train you on any walkers or canes. Most of you are not going to need a knee walker. That's for our ankle replacements, but we just kind of tossed it in there. If you don't own a walker already, when you come in to see us, a case manager is going to meet with you about getting all of the equipment together before you leave the hospital so that you feel secure that you've got everything that you need with you. We're going to teach you how to use the walker. We're going to size it to the correct height so that you feel safe and good using it when you get home. Some of our anterior hip patients, most of them, I'd say 99% of them, will go home on a walker. But if you're here for an extra day or two, we'll start retraining you back to your cane. We usually recommend you use the walker initially and let the outpatient or home health therapists work with you on getting back to the cane and more safely independent with those devices. The exercises we strive to have, we as therapists will do 1 set of 10 with you on your surgical side. Okay, that's to keep us efficiently moving. If all of you guys have a joint replacement on the same day, then we have to see all of you twice. So for efficiency's sake, we keep it to 1 set of 10 as an instructional component, right? And as you start to get independent, we may knock exercises completely out of our plan with you. We may just focus on the functional mobility if you're doing them well enough on your own. Over the course of the first few days when you get home, though, we do want you to be building up to being able to do 3 sets of 10 to 15 repetitions 3 times a day. So if you do that math, you're somewhere around 100 reps a day. Okay. We figure you bought into the joint replacement, and this is what's going to get you back to your real life, pain-free, out back to your real life. So we're hoping that you'll buy in with us. Okay. So we'll give you some handouts of these. If you choose to start doing these before you start coming in for surgery, that'd be great. The stronger you go into the OR, the stronger you come out of the OR, and the stronger you are when we start to work with you, okay? Not to mention that muscle memory sort of kicks in after the surgery if you've worked on these a little bit so that your leg kind of knows what I want it to do and what I'm trying to do with it, okay? So they're in your book. The ones in the binder in the book are circled with big red circles. They're the ones that we're going to focus on first. The ones that don't have big red circles, those are the ones that your outpatient or your home health therapist is going to progress you towards as you continue to improve in your range and strength. Occupational therapy actually doesn't start until day 1. Okay? They don't come in on day 0. That's just physical therapy that comes in and gets you started. Occupational therapy will start on day 1, and some of you may be going, occupational, I'm already retired, I don't have a job, I don't have to, do that stuff. As one of my occupational therapists said, they work on the things that occupy your time, okay? And so their main focus here in the acute care setting with our joint replacement patients, you now have a painful, slightly swollen, typically brand new joint replacement. And you need to put your shoes and socks on and your pants on. You need to be able to take yourself to the bathroom and back, right? And so that's their focus. Teaching you the techniques to help you get dressed and maintain your independence to keep yourself dressed and bathed and toileting without needing a caregiver there with you, okay? And so they're gonna come in and they're gonna teach you a whole bunch of adaptive equipment. And that's what we've got here for you just to kind of get familiar with. So this is, anybody know what this is? Very good. This is a sock aid, okay? Any of you that don't know, this is like fishing for your socks, all right? You put the sock on, you throw it out there like you're catching a big old catfish, put your foot in it, and slide it up. Now I don't have to bend over, okay? So if I'm getting a posterior hip replacement, I don't have to worry about that bending precaution. I can do it with my hands. They'll give you a long-handled sponge. This is so that you don't, again, have to bend over while you're in the shower to reach down to get your lower leg and your feet, okay? They'll teach you also to wrap a towel around it because once you're clean, it helps you dry off also, Okay, so it can be used both. If you need to, if you don't wear those slip-on shoes, they'll teach you how to use a long-handled shoehorn, again, just to keep you independent in getting your shoes and socks on after your hip replacement. And then most of our hip patients do leave here with a reacher or grabber, as they call it, right? So this is great. Picks everything up so that I don't have to bend over. I'm walking with my walker. If I'm walking with a walker, I probably don't have the balance quite yet, much less the range or strength to bend over and get something off the floor. So instead, I can carry this with me. I can get things off the floor to help me out. The good thing about the ones that we give you, they also have this component right here. It's called a dressing stick component. So it allows you to kind of loop into your pants loop or loop into something to get your pants on also, so that you can pull them up above your hip, above your knees, and then stand up and finishing getting them on your body. It also lets your caregiver know that you need a drink. Give me this. I need my pain medicine. Okay. And then this last thing is a leg lifter. Now, not all of our patients go home with a leg lifter. This one we do on an individualized basis. And essentially, the gentleman that invented the invisible dog walker realized he could make more money in the medical field than he could in toys and novelties. And so you put the loose end, the leash, through your hand through the leash, and then your invisible dog goes around your foot, right? And so then you can lift that leg up into the bed or lift it back down to the floor, which allows you to use your upper body to help you with that while your leg is still healing up and getting a little bit stronger, okay? Again, our goal is to make you independent in getting in and out of bed. It's great if you have a caregiver that can help you, but it's even better to be independently doing that type of thing, right? So we want to make sure that you can get yourself up to the bathroom in the middle of the night and not have to ring out or have somebody help you do that, okay? Now there is, I'm not sure Michelle went over our #1 rule on the orthopedics floor. So from a therapy perspective, the #1 rule is to not fall. We want to keep you safe, right? I don't allow people to use the F word while I'm working with them. And so, the F word being fall, just so we're clear. And so that first time we get you up out of bed that first day, we're gonna leave you up in the recliner for the better part of the day. You're gonna get up with PT or OT, you're gonna see the other one that hasn't seen you, and then you're gonna stay up until the therapist comes back to get you back in bed.
That's like when you use the other F word.
Yes, exactly. So you are expected to sit up in a recliner for a fair amount of the day and ring out for the nurses to help you go to the bathroom and things like that and readjust as you need to. But we will be sitting you on what's called a chair alarm. So we wire all of you for sound. Okay, we put every one of you on a chair alarm that first day so that if you try to stand yourself up, it will alert us that you're standing up without assistance and then hopefully cue you to sit back down. Please do not be offended when we put you on that chair alarm. It is for your safety. You've had major surgery, you have a nerve block, and we're giving you narcotics. So not everybody comes out completely lucid like they are today, okay? Takes a little time to get back to normal. And so we want to keep you safe. We don't want you to forget that you had a major joint replacement, stand up, forget that you need a walker, trip, fall, leg gives way, any of those things, okay? So everybody's on that at least for the first day, if not until you go home from surgery.